introducing myself. My name is Tony Chepkwony. I work at the National Cancer Control Program. I am a resident epidemiologist, and I support the second pillar of the program that majorly deals with cancer diagnosis. So through the TWG, I play a key role, especially in matters cancer diagnosis and also strengthening health systems. So part of what we do at the program is to look at the sample referral mechanisms, both at the national and the county level, and also improve on in terms of lab infrastructure, especially enhancing the HPV diagnostic workforce, and also sample referral mechanism for breast cancer samples. So I want to give this opportunity for the first presenter. And before that, I think we are going to have a small pre-test so that we can see the level of knowledge for the participants with regards to the topic of the day. So remember, the month of October is when we are commemorating Breast Cancer Awareness Month. And this webinar is timely in terms of ensuring that we do a lot of advocacy with regards to breast cancer. So we are going to give you around just a few minutes, like 5 minutes or less than that, because we have 4 presenters on board so that we can proceed with the first presentation. So kindly take the quiz, and then I will go ahead and introduce the first presenter.
Thank you for attempting the quiz. For those who still haven't attempted the quiz, it's currently running. Kindly attempt those questions before we begin. And in the meantime, participants, you can engage with our panelists by just letting them know where you're joining us from through the chat and say hi to our panelists for today. Thank you, Kefa from Kisii. I can see we also have Mandera County well represented by Adam Noor. Lucy from Nairobi, thank you. Keep them coming and also attempt the questions if you haven't yet. Thank you, Kericho County, Nyeri County, Busia County, Omar all the way from Kwale, karibu sana. Garissa County is also well represented. Nyandarua County, Kisumu. Thank you all for joining us today for this session. I think, Tony, we can proceed with introductions. I can see a good number have attempted the quiz. So we can just proceed with the introductions for the presentations. Thank you.
Yeah, thank you so much, Nelson. Good evening once again. As I had stated earlier, I'll be the moderator for the session, and my name is Tony Chepkwony. So at this moment, I want to introduce the first presenter. So the first presenter will be Dr. Joan Paul Labor. And Dr. Bor is a medical doctor by profession and also a seasoned global health professional. So Dr. Bor has 20 years experience in terms of Kenya's public health sector. And that basically is on a focus on clinical care, health systems strengthening, and healthcare management. So she has a specialization in non-communicable diseases with a particular emphasis on cancer. And she's been instrumental in formulating and implementing national policies and programs. So this includes the National Cancer Screening Guidelines and also the Breast Cancer Screening and Early Diagnosis Action Plan. So Dr. Bor currently leads the development and execution of policies under the National Cancer Control Strategy running between 2023-2027, while continuously advancing her expertise in health system strengthening and also strategic leadership. So Dr. Bor holds a Master of Science in Global Health and Non-Communicable Diseases from the University of Edinburgh. So at this moment, let me take this opportunity to welcome Dr. Bor for the first presentation. Karibu Daktari.
Thank you very much, Tony. Good evening, everybody. And it's a pleasure to join you this evening as we are going to delve into matters of policy, and not just policy, but personal action. So mine is to introduce the topic and mostly speak on the policy and the burden of breast cancer in Kenya and globally. Let me just try and make sure that I hope you can see my screen clearly and that you can hear me clearly. So I have titled my presentation today, Policy to Personal Action, Advancing Breast Cancer Control in Kenya. And the reason for this is that, as you know, this month, October, is Breast Cancer Awareness Month, and that is what we are commemorating. And my presentation will cover briefly about the Breast Cancer Awareness Month 2025. We look at the global picture, the burden and the response, and then we look at our own reality in Kenya, the national frameworks, and your role in these. I'm assuming that most of us here are healthcare workers, and I felt that it's important to just remind us what is our role. So Breast Cancer Awareness Month is commemorated every October globally. In Kenya, we are not left behind. In fact, people know October as Cancer Awareness Month, right? You'll find that people even think that cancer awareness, that October is about all cancers, but really it is Breast Cancer Awareness Month. And this year, we are commemorating Breast Cancer Awareness Month under the theme, Beyond Awareness, Personal Action for Breast Cancer. And we also have a number of hashtags, maybe I'll post them after, that we are using on social media channels. The reason for this is that we feel that this was guided by the National Technical Working Group on Cancer Prevention and Early Detection. And our observation is that people know you are supposed to be screened. People know that, there is breast cancer. And however, when it comes to taking up screening, it is not as well taken up as it should be. And that is why we feel that personal action, it is important. Kila mtu achukue jukumu, apimwe na ajue hali yake, or to get to know where you stand when it comes to breast cancer. So that is about Breast Cancer Awareness Month. In terms of the global picture, breast cancer is the most commonly diagnosed cancer globally now. It has overtaken lung cancer. And in 2022, which is the last Global Can report, 2.3 million new cases were diagnosed. And this incidence is rising fastest in low and middle income countries like our own. So you can imagine these countries have health systems that may not be as well prepared, and they are the ones with the highest, the disparity and the inequalities when it comes to healthcare and access to services. I picked this from the Global Can just to show us the age standardized rate for breast cancer among both sexes in 2022, and you will observe that, of course, the deepest blues are standing for over 71 cases per 100,000 to 105 per 100,000. So you notice that it is countries like America, like Australia here at the bottom, and some parts of South America and Europe as well. Tony, I see some hands are raised. Is there maybe a problem?
Not really, Dr. I think you are good to proceed.
All right, thank you. So Kenya, right here, you can see where we are. And we are somehow in a shade of blue that is maybe in the range of 40 per 100,000 in terms of new cases. Now, when it comes to deaths, I also picked up this slide. You see that the countries that had the highest incidence are not the ones with the highest deaths, isn't it? Because the lighter shades are the ones with fewer deaths. These are 2.3 to 11 per 100,000. And you can see, like countries like ours are among those with over 19 to 38 per 100,000. So you can see the disparity that countries with the highest cases are not the ones with the highest deaths. We have fewer cases diagnosed at this point, but we have more deaths. So that is something that tells us that there are inequalities and that we need to do more about this. What is the global response? The global response is the Global Breast Cancer Initiative, which was launched by WHO in 2021. And what this initiative is looking at is 3 targets that were set with a goal of averting 2.5 million deaths due to breast cancer by 2040. And the first pillar is on health promotion, and with early detection being the end. And here we are looking at public health education to improve awareness of the signs and symptoms and the importance of early detection and treatment. We want to achieve diagnosis of our breast cancer cases, at least majority of them 60% in stage 1 and 2. I can tell you that right now, that is not the case. It is more likely that we are diagnosing 60%, over 60% in stage 3 and 4. So we need to do better. And I'm sure you will agree with me on that. Then on the second pillar, it is timely diagnosis. Sometimes you find that a woman has a lump, and by the time they get to know that this is breast cancer, it has taken them over 6 months. So here we're looking at reducing this to 60 days. to make sure that they're evaluated, they get their imaging, they get their tissue sampling and pathology completed within 60 days. And how are we going to do this? By educating the health workers and the public. And we hope that even the activity that we are doing right now is contributing to this particular pillar. Pillar 3 is on treatment and completion of treatment, all types of treatment necessary, and ensuring that 80% of the clients undergo treatment and recover fully and return home. So if you remember 60, 60, 80, you'll be good to go, that these are the targets that we are working towards. What is our reality here in Kenya? In Kenya, breast cancer is the leading cancer among Kenyan women. As I said, many are still diagnosed late. We have made some progress, but I think I'll show you first these slides, which show the burden of cancer in Kenya. And this is overall among men and women. And out of the 44,000 new cases, over 7,000 are breast cancer, followed by cervical cancer, which you realize now those are women's cancers. And then when it comes to deaths, out of the 29,000 deaths, breast cancer accounts for 3,000, almost 400 deaths, while cervical cancer contributes to more deaths. So while our cervical cancer is the leading cause of cancer deaths, breast cancer is number 2, and you can see that the two are affecting our women heavily. So just to complete this, we have made some progress. We have set up regional centers. We have regional treatment centers, in addition to our national referrals offering comprehensive treatment. We have screening guidelines in place, and also we are integrating under UHC, including our oncology benefits package under SHA. Yes, it may not be covering adequately, but it covers a substantial, actually a significant figure, including even the access programs that we have, including one on Herceptin, which is specifically for breast cancer. Our focus now would be on implementation and ensuring equitable access, even as we look at our national policies, which are these ones here. We have our Kenya Cancer Policy, which guides us, big picture. And then we have the National Cancer Control Strategy, of which we're implementing the third one, and all these other guidelines. I think I missed to include the screening guideline, the latest screening guideline, but there is one, and the treatment protocols are currently under review. All these are available, and I will share a QR code where you can download the latest. So when it comes to the National Cancer Control Strategy, which is really our guiding framework, the vision is a nation free from the preventable burden of cancer, including breast cancer. And we are talking primary and secondary prevention. And this strategy, is implemented through 5 strategic investment areas, which we call Pillar 1 up to 5. Pillar 1 being prevention and early detection. Pillar 2 being cancer imaging, pathology, and lab medicine. Pillar 3, treatment, palliative care, and survivorship. Pillar 4 is on advocacy, partnerships, and coordination and financing. And Pillar 5 is on strategic information, registration, and research. So these 5 pillars, through implementing these 5 pillars is how we make strategic interventions for breast cancer. I'm coming to the end of my short presentation, and I wanted to just highlight our role as healthcare workers, because I know majority on this platform today are healthcare workers. What is our role? Our role is to turn that awareness into action. And how do we do this? Number one, on a personal level, as healthcare workers, we need to prioritize our own screening and those of our family and friends. And this month, a number of facilities are offering subsidized treatment. Subsidized screening, mammograms, ultrasounds, they are being offered at a subsidized rate. And I think we should be the first ones to take advantage of that. Secondly, on a professional level, we need to offer clinical breast exams we need to cancel clients and refer every eligible woman. We make sure that no woman is left behind. For those of us in administrative positions, we also need to consider how can we offer free, services especially during this month. Can we, offer free mammograms or at a subsidized rate or at or even the ultrasounds? Can we publicize the CBEs? But overall, our small and consistent actions will create nationwide impact. So I hope you're going to be taking up that, and so that together we can turn the tide on breast cancer. And I would like you to scan that QR code so that you can access the NCCP the NCCP websites where you will get the latest policies and guidelines. Back to you, Tony, as you introduce the other speaker. I will leave this for maybe a minute so that people can scan that. Thank you very much for your attention.
Yeah, thank you so much, Dr. Bor, for the good highlights. And I believe that the audience is well conversant with in terms of the global and also the regional breast cancer burden, and also looking at the strategic policy documents as pertaining to the National Cancer Control Program. So I am going to go straight to the next presenter of this day, and I'm going to introduce Professor Daniel Ojuka. So Professor Ojuka, is currently the Dean Faculty of Health Sciences at the University of Nairobi. And he's an associate professor at the Department of Surgery at the University of Nairobi. So Prof. Ojuka is a general surgeon and has specialized in breast surgery and has been involved in the technical working group for setting up guidelines for breast cancer screening and treatment with the government. So his research interests are pertaining to breast cancer and also medical education. And with regards to his PhD, that was in surgical education, and he's been the president of the Surgical Society of Kenya, currently the governor of the American College of Surgeons, that is for the Kenyan chapter. So Professor Ojuka has been the regional leader for the International Christian Medical and Dentist Association, and is now a member of the International Board of the same. So he's going to take us through the principles of breast cancer management. And at this point, I want to introduce and welcome Professor Ojuka for the next session. Karibu, Prof.
Good evening, Tony. Are you hearing me?
Yes, we can hear you well, Prof. You can proceed.
Okay, thank you. Thank you for that generous introduction. Here to discuss principles of breast cancer management, just an overview. I know we have a mixed audience, and we will discuss the majority of the details in the Q&A. I think this particular slide has been done well by Dr. J.P. Bor. Just to add that effective management is crucial for improving survival rate and quality of life, as Dr. Bor indicated, that we have increased incidence in our part of the world with, again, increased mortality. And so this presentation is just going to outline key principles of management of breast cancer from diagnosis through treatment and then follow-up. Maybe just to begin by discussing what breast cancer is. Breast carcinomas arise from the same segment of the terminal duct lobular unit. And so the cells from there then grow uncontrollably. They can either affect mostly duct or the lobule. So they will either be ductal or lobular carcinomas. There is a group of diseases that are called, in UK, they are called B3 lesions. Essentially, preoperative core biopsy lesions that are of uncertain status in terms of their malignancies. I think if you read other literature from US, they were classified by Page and DuPont in terms of benign lesions. I think Page and DuPont has non-proliferative, proliferative without atypia, and proliferative with atypia. And so if you're considering B3 lesions, those will be proliferative diseases with or without atypia. And because they are mainly benign diseases, they may not be part of our discussion, but they then have an increased risk of becoming cancerous. So if you look at the pathologies in terms of the pathology of carcinomas, so like I say, ductal carcinomas, you will have variety, but majority of it will be classical, or what is there called classic, but there are various types. Tubular, mucinous, cribriform, medullary, papillary, micropapillary, apocrine, neuroendocrine, metaplastic. Metaplastic in itself has another subclassification, which you can see there. So either purely epithelial or mixed epithelial and mesenchymal. And so all that can be the pathology that you will get. So the pathologies who are present, probably if they are to show you what type of or what subtype of breast cancer that you have, then you will have this. And all these are mainly ductal. All that classification is actually ductal. And then we think about lobular again has mainly 5. So classic, and then pleomorphic, histiocytoid, signet ring carcinoma, and tubulolobular carcinomas, which are again a type of lobular cancers, as it were. So that is what you will get as the pathology of breast cancer. And then, of course, we know that there are molecular types that now has the lumino A, lumino B. The high and low Ki67 depends mainly on the lab. And so the lab probably will tell you whether you are thinking about high Ki67 or not. Majority of them will be between 15 and 20% Ki67 as the dividing line. So below 20 low, above 20 high. Some will use 15 as the dividing line. But yes, you will have lumino A, lumino B. Lumino B-like is essentially a triple positive disease. And then you have HER2 enriched and basal-like, which is essentially the triple negative as we know it. Except that if you do EGFR or CD4, CDK4, you will find that they are positive in the basal-like. That's why they are called basal-like. And so that is the pathology for what breast cancer is. And then if you look at the risk factor, which is essentially part of the principle. So number one, know what breast cancer is. So if you are a healthcare provider, you're talking to a patient, then you can say breast cancer usually breast tissue that are uncontrollably dividing itself within the breast and then can spread beyond the breast. And there are various types, ductal, lobular, and the many things that we have discussed. But then for that patient, you need to look at the patient and then say, what are the risk stratifications? So generally, we have high-risk patients and then the average risk patient, which is the same as the normal population. So risk factors are modifiable risk factor and non-modifiable risk factor. So modifiable risk factor is nulliparity, because you can modify that and then breastfeed, not breastfeeding, or breastfeeding smoking, alcohol, obesity, physical activity, diet. Those are modifiable. Then oral contraceptives, hormonal replacement therapy, and fast pregnancy after 30 years. All those you can control. The ones that you cannot control is the age, the sex, family history, the breast density, menarche before 12, and menopause after 55 years. And then personal history of breast cancer or personal history of breast pathology and radiation exposure. Sometimes it is not modifiable because it might have been used to treat a disease. So you can't really modify it. That is why it is not modifiable as a risk factor. And so this is the history that you take from the patient. And if you are getting maybe apart from age and sex, if you are getting more than 3, then probably you are thinking this is a patient who has a high risk, especially the non-modifiable. Then you think these patients are high-risk patients. And then, of course, the presentation. How does breast cancer present? In our part of the world, majority of it would have symptoms, but there are patients who you could see because of the screening that we are beginning to do in our part of the world, and there are people who do them. Then there are people who present as asymptomatic. And then you have people who present with breast mass, nipple discharge, skin changes. Breast pain is a very rare presentation for breast cancer. I think only about 5% will present as breast pain. Then you have changes in size or shape of the breast, ulceration of the mass, and then you have a variety of symptoms that are metastatic symptoms that include bone pain, chest pain, headache, and things like that. And then physical examination, what you'd want to do is characterize the mass. Then you look at skin dimpling, tethering, or dilated veins, nipple invasion, check for axillary nodes, not just axillary, but also infraclavicular and supraclavicular nodes. And you should look at those basins and find out whether there are nodes there. Then, of course, the Paget's disease association with redness or eczematous lesion around the nipple. And then you can have patients who present with edema or pudule range, as it were. So, as we had indicated, the characterization of the mass that will indicate that it is probably suspicious would be hardness, irregularity, or focal nodularity, asymmetry compared with the other breast, and fixation to the skin or to the muscle. Metastatic symptoms, like I indicated, will include bone pain, symptoms of hypercalcemia, which include thirstiness, that people who present as thirsty, or kidney diseases, breathing difficulty, abdominal distension, headache, altered cognitive function, localizing neurological signs, because there are some patients who may present with fractures of bone and can be fracture of the spine, so they may present with localizing neurological signs and jaundice as well. So for patients who present, whichever way they present, you want to probably do triple assessment. Triple assessment consists of clinical evaluation, which is history that we have gone through, on physical exam, and then imaging, and then histopathology. If you look at that, those 3, there is increasing invasiveness because physical exam, history, you probably you've not even touched the patient. Physical exam, you're touching. Imaging can be more invasive than physical exam. And then histopathology, now you have to use a needle to do the core biopsy. So you can have a situation where you just do 2, clinical evaluation, history and physical exam, and imaging, and then you decide this is a benign thing, it is a small disease, I'm doing nothing more. But so that is why I think this is a cost-effective way of managing, or a cost-effective way of diagnostic approach, because you may omit histopathology. In some cases where the imaging then indicates that you are dealing with a benign disease. When it comes to imaging, there are a number of modalities. I think the most common ones are mammography and ultrasound. So mammography would be the gold standard for screening and diagnosis in breast pathology. And mammography can either be for screening in asymptomatic patients or diagnostic in those who come with symptoms. And for screening, especially for those over 40 because of breast density, are for diagnostic. So long as a patient has symptoms, they are meant to do mammography whichever age they are. So I know we usually think about age of 40, below 40, but so long as a patient has symptoms, the standard diagnostic imaging would be mammography. I think that needs to be emphasized. And then the issues of ultrasound would be complementary to mammogram or can be used as the initial imaging evaluation for palpable breast masses in patients under 30. But remember that even when you use it in that way, still the standard should be mammogram. And then, of course, the evaluation of axillary lymph nodes or guidance for biopsy for interventional procedures for breast and axilla. And then MR is used especially when in patients with high risk or of younger age or patients with history of chest or mantle radiation therapy at young age. Or patient with personal history of breast cancer and dense tissue or diagnosis by age of 50. And patients who present with occult breast cancer. Occult breast cancer in this particular situation means that you are not getting a palpable breast pathology, even with the ultrasound sometimes, and the patient either present with axillary nodes that at biopsy shows they have breast cancer, or they present with fractures, and you are looking for where the cancer is coming from, and it's difficult to get them. So those are called occult breast cancer. And so the outcome of imaging, whether it be ultrasound, mammogram, or MRI, will either be BI-RADS, and so it can be 0. And if it is 0, you repeat with a difference modality. If it is 1, that would mean it is normal. So the patient can now do annual screening depending on the age. And then BI-RADS 2, benign disease, that patient can either do annual screening depending on the size and the type. In other words, if it is benign but it's a B3 lesions, some of those lesions may require biopsy, things, I mean, depending on the size. So if if fibroadenoma and is more than 3 centimeters, the guidelines require that those that are more than 3 centimeters or they are increasing in size, that means you have done more than once, they may require excision, but normally less than 2 centimeters may just require just annual screening. Of course, that's why I'm saying depending on size and type. Then BI-RADS 3, probably benign, short-term follow-up. BI-RADS 4 would be suspicious for malignancy. You do a core biopsy, same as BI-RADS 5. And BI-RADS 6, that is BI-RADS 6, sorry for the spelling. BI-RADS 6 would be biopsy-proven malignancy. So the core biopsy results could either be benign, so you follow up, or excise depending on pathology and size. And then it can be indeterminate, that means you can repeat. Usually the guidelines would do guided biopsy, you do a guided biopsy for that matter, or you can perform excision of biopsy. In cases where even the guided biopsy is still yield indeterminate results. And then if they are malignant, for those of us who are general medical officers or clinical officers or from the nursing fraternity in level 1, level 2, level 3, then you need to send to level 4, where there will be general surgeons or breast surgeons who will then now take over and do immunohistochemistry for molecular typing and staging, and possible genetic counseling and testing, depending on the risk profile of the patient. So staging, usually, the normal thing would be do CT scan for chest and abdomen. And the reason why you want to do that is normally the breast cancer goes to the lung and to the liver first, and then it may go to the bone. So that is why the CT scan is important, because it can show you bone lesions, either in the spine for the abdomen and chest, or even pelvis for the abdomen. So that's why those staging modalities are important, because the predilection is to lung, liver, and bones. And then ultrasound of the abdomen. There are guidelines that says patients with the T1 lesions, T2 lesions, T1 lesions and below with no symptoms, you can actually just do ultrasound of the abdomen to check for the liver and then do chest X-ray. Although majority of the patients in our part of the world will present with the late stage 3, stage 4, or late stage maybe 2B, and those kind of patients then will require chest CT scan, chest CT scan and abdominal CT scan. And so we should be careful in terms of the staging. There are patients that you may do a chest CT scan and find that they have indeterminate or equivocal nodules that can't be determined, either by radiologists mainly. And so those kind of patients may benefit from PET scan. So PET scan would not be the first thing you go for, but it could be where there is less than 1 centimeter nodules, there are multiple in the lungs, maybe PET scan then may help. But of course, we know that there are sizes that PET scan will not also be helpful, even in such situations. So staging, how you stage, like I said, there is TNM staging for breast cancer. So T is clinical examination, imaging, and surgical specimen. So you can do, usually when you see a CT, a small c as a prefix and a T, that means it's clinical. And that clinical includes the physical examination and imaging, by the way. When it's P, then it includes, then it means pathological. So the initial imaging should indicate the absence or presence of additional lesions in ipsilateral, axillar, and contralateral breast. Otherwise, review or repeat imaging. I think one of the most important things that I want to emphasize here is those of us who take care of patients, when the patients come, please just ensure that they actually have imaging, the basic imaging for T. That would be mammogram. If they are symptomatic, they need a mammogram. And that mammogram should be a mammogram of both breasts, because it will help you in doing the T, and it helps you then say whether there is absence or presence of additional lesions. That is why it is important. So if a patient comes with breast cancer and has no imaging, please request for that imaging. And then the end stage again would be clinical examination, imaging, and surgical specimen. So preparative staging of N, you can get that through clinical examination plus imaging that will include CT scan results. And then M, would be imaging as well, CT scan. So early, the people who say early breast is will be T2 and below. Like I said, you can do chest X-ray and abdominal ultrasound. Locally advanced, then you will require CT scan, abdominal, pelvic, and bone scan if necessary. Bone scan would be necessary if the patient present with bone pain. So if a patient present with bone pain, those type of patients then will require that you ask for a bone scan. And then, of course, other tests are indicated by clinical evaluation, including CT scan of the head for CNS symptoms. Because remember that breast cancer, apart from the lung, liver, and bone, can also go to the brain. And so those that go to the brain then will require CT scan of the head if they have headaches. And so the T stage can be TX to T4, NX to N3, M0, or rather MX to M1. TX just means you really can't evaluate the disease, or wherever X is shown. And then, of course, it can be from T, which is T1, T2, T3. T3 is more than 5 centimeters. T2 will be between 2 and 5. T1 will be between 0 to 2 centimeters. And then, of course, T4 would be if it is involving the skin, if it is in, and the skin here means the skin edema, there's ulceration. Usually dimpling or tethering are not considered T4. And then, of course, they are fixed to chest wall. So those will be T4. And then N3 would mean you have clinical N3 would mean you have infraclavicular or supraclavicular nodes. And then M1 is you have either cervical nodes, if you are considering nodes, or any other metastatic sites that we have talked about. So management, I may not go into the details of this because it's very detailed. It depends on stage and molecular type. And depending on what you have, you will get surgery, you will get chemotherapy, you will get hormonal therapy, get radiotherapy or targeted therapy, or a combination of all these, depending on the stage. So early diseases, if you, for example, you have early disease and you have a hormonal positive disease, then it is possible that you can do surgery. If it is very small, less than 1 centimeter, not negative, then you can do oncotype if you have, and then decide, depending on the score, whether you benefit from chemo or not. So sometimes you can just do surgery and then you do hormonal care. So you can get away with surgery and hormonal care. If it is, there are patients who may require chemotherapy, and then you do surgery, chemotherapy, and hormonal therapy. There are patients who will require radiotherapy. There are patients who will require targeted therapy, and in this case, you are thinking about HER2 disease and or diseases. There are other drugs now that then you think about even in triple negative, especially if you do genetic testing, BRCA. If you have BRCA positive genes, then there are drugs that will be you would require. So those are targeted therapies. And there are many combinations that we may not finish this evening. So this is non-metastatic, just an examples of the things that I've been talking about. So sometimes, especially when you think about HER2 positive disease, if you have node positive or if you are triple negative disease with node positive, even when they are small, then you may need to start with neoadjuvant therapy before you go to surgery and other local treatment you start with neoadjuvant because they are predisposed to metastatic, so you want to start by mobilizing them from the system before you now start dealing with them locally. Metastatic disease mainly will be palliative, and that palliation can either be hormonal or any of the drugs that we are talking about. The things that you want to really focus on is quality of life while avoiding serious side effects. In hormonal positive diseases, you can use hormonal treatment until you have vital crisis. You can use single agent or double agent, and then you can use surgery in cases you can do palliative surgery, and then radiotherapy, especially in cases where probably you think about bleeding and you want to stop that. And then, of course, other agent and genetic testing and counseling as well. For follow-up, for the first year, you want to do 3 history and physical examination every 3 to 4 months. The second year, every 4 months. Third to the 5th year, every 6 months, and thereafter annually. And then, of course, mammogram can be done 6 months post surgery, and then annually, and then pelvic examination annually for this patient. I thank you. Back to you, Tony.
Yeah, thank you so much, Prof, for that insightful and enriching presentation. And I want to really believe that the audience, from the detailed session that we have, we've had, we can confidently say that the audience is well informed in terms of breast cancer management. So we truly thank you for the wealth of knowledge that we have gotten from you, and also for breaking it down very clearly. So any question that is directed to any of the panelists, kindly let us have them on the chat box, even as we proceed. So having focused on the burden and also policy and strategic frameworks, and also looking at the management for breast cancer, I want us to go to the next presentation, and this will actually be one of the modalities for breast cancer diagnosis, looking into the imaging aspect. So I want to introduce the next presenter, that is Dr. Nuru Chebet Mbarak. So Dr. Nuru Mbarak is a consultant radiologist at the Kericho County Referral Hospital. Dr. Nuru attained her undergraduate degree and also a master's in radiology and imaging from Moi University. She has also done a mini fellowship in breast imaging from Apollo Radiology International, that is Hyderabad, and a preceptorship in interventional radiology at the Eldoret Radiology Specialist Radiocare. So she's a passionate radiologist with a special interest in women's imaging, radio oncology, and also interventional radiology. So I want to welcome Dr. Nuru for the next presentation. And the topic for this part will be the critical role of imaging in breast cancer care. Welcome, Dr. Nuru.
Thank you very much, Tony, for that very kind introduction. I would like to share my screen. As you've heard from Prof, imaging plays a very critical role. Just a minute. In cancer management, all the way from screening and diagnosis to follow-up of treatment, staging, and even disease surveillance going forward. Where has my slide disappeared to? Just give me a sec.
Yes, so we can keep the questions coming. Thank you for those good questions that are coming in. And thank you for also the good attendance. I see that we are doing well with regards to the number of participants.
Okay, so I'm back. Are you able to see my screen?
Yes, we can.
Okay. Is it in slide share mode?
Not yet.
Not yet. Radiologists are not supposed to be technologically challenged, but here we go. Small lesions. So CT scans of the chest, the abdomen, pelvis, and brain, and bones, and how we're going to apply. And then imaging and biopsy. And this is where the clinicians on the ground come to play, because a thorough clinical history and physical examination is what will determine whether this patient is going to go for imaging. And so you have that as the first component, and then imaging using the different modalities, and then biopsy, which is also image guided, and then now having a comprehensive approach to this. So for mammography, I know we have a mixed audience, and mammography is a low-dose X-ray. Basically, it was designed to go through breast, because breast is very soft tissue. The current KVP that we use for other modalities would just go through the breast and we would not see anything. So we needed a lower dose so that you're able to visualize the internal structures of the breast, and that's how we have mammography. And we know it plays a vital role in early detection of breast cancer, and it has been shown to reduce breast cancer mortality, one of the only screening methods that have been shown to directly reduce cancer mortality. And we have two types of mammogram. So you can either have a screening mammogram, which is done in an asymptomatic patient, and we'll see the algorithm or how you're supposed to approach such a patient. And in this screening mammogram, we use two standard views, the CC view and the MLO view. And for diagnostic mammography, once you have done a screening mammogram and there is an abnormality, or the patient already came with symptoms, then you're going to have additional imaging. This will include spot compression views, magnification views, true laterals, and DBT, among others. And so this is the age-based screening recommendation from the Kenya National Screening Guidelines. For patients, so being in a low to middle income country, we had to use clinical breast examination to try and capture these patients early. And for patients between 25 to 34 years, that's what's recommended every year or every 3 years. So 1 to 3 years, you should have a proper clinical breast examination. And then between 35 to 39 years, clinical breast examination and ultrasound. In case there's an abnormality in this age group, even though they've not qualified for mammography yet, mammography is still a modality that will give you information. And then 40 to 55 years, you have annual CBE, clinical breast examination, plus mammography. 56 to 74 years, it is now biannual. So you skip 1 year, every 2 years you get a CBE and mammography. And above that, above 75 years, you consider individual risk factors, health factors, and preference. So these are the current guidelines from the National Cancer Control Program. As we said, we had the old mammography and digital mammography. And currently, we are mainly using digital mammography. First, there is reduced radiation dose, better contrast resolution and visualization of structures, and you can be able to get more breast tissue, including tomosynthesis, which tries now to slice the breast, and you see thinner slices of the breast and reducing overlap. And telemammography is possible, so increasing access to areas where there are no radiologists. So as we said, the standard views are the CC and MLO, which is the standard views for screening, and additional views of lateral, compressional cone views, cleavage view, rolled view, magnification views are added when abnormalities are identified. The main thing about mammography is that we have a problem of dense breasts obscuring lesions. So when you have dense breast, the lesions might be obscured by the fibroglandular tissue of the breast, but we know that breast density decreases with age. Unfortunately, this is not the same for African breast. You can have very old patients with increased breast density, and patients on hormone replacement therapy will also have increased density. For patients who are on tamoxifen, who've been treated for breast cancer before and are on tamoxifen, you might have a reduced breast density. Some of the items, some of the features you're able to assess on mammography are symmetry, mass lesions, architectural distortions, calcifications, and any associated features. We are going to look at the lexicon to help us with this. Because of the time we have in this presentation, then we are going to have to summarize. So the breast composition is the first component of assessment. You need to assess whether the breast is entirely fatty, it has scattered areas of fibroglandular tissue, it is heterogeneously dense, or it is extremely dense, and categorize this according to the SCR criteria, which is the American College of Radiology criteria. So for breasts which are type C and D, we consider them dense, and this will require supplemental imaging with ultrasound. The other aspect you can assess is masses which are identifiable on mammography. And once you find a mass, then you're going to define the shape, the margins, and the density. The features you're going to see here will give you either a higher or lower suspicion of malignancy. So well-defined oval lesions are less suspicious. Lesions which are poorly circumscribed with indistinct margins or speculated margins are more suspicious. And those ones which are high density, which means brighter than the breast tissue, are more suspicious. Then we look for asymmetry. Both breasts need to look the same. We can have anatomical asymmetries because one breast might be larger than the other, but you need to define whether the asymmetry is focal, global, or developing, and further evaluate that. And then architectural distortions with no visible mass, and then calcifications. When the main reason mammography is a high achieving tool is because it can pick up calcifications better than ultrasound. And so when you find calcifications, you further go and categorize them based on morphology and distribution, and those are the terminologies that we use. And then associated features including skin retraction, nipple retraction, skin thickening, trabecular thickening, any identifiable or accounts. What you're going for BI-RADS category universally with other clinicians, other radiologists, and you'll know what to do next. So if you have a BI-RADS lesion, it means that this patient will need additional imaging and MRI. So this patient does not go home. They're supposed to mammogram. If you have a BI-RADS 1, there is no pathology identified on mammogram, and there is no risk of malignancy. The patient will continue with routine screening. A BI-RADS 2 lesion. So when you give a BI-RADS 2 category, it means you're very sure that this is a benign lesion. It could be a simple cyst. It could be a benign calcification, for example, vascular calcifications. These ones will also continue with routine screening. BI-RADS 3, which is probably benign, which means some of the features are not very overtly malignant, and if there is any change in between, then that patient is moved to the higher BI-RADS category and undergoes the next evaluation. If it remains the same, they go back to routine screening. For suspicious lesions, which is BI-RADS 4, and they are further categorized into 4A, 4B, and 4C. These ones will definitely require a biopsy and further management. And then BI-RADS 5, highly suggestive features based on the lexicon, definitely a biopsy and further management. For patients who have known malignancy, biopsy-proven malignancy, then they are definitely BI-RADS 6. So this is the same category that BI-RADS categories that we use also for ultrasound. And then there are small changes when we come to MRI, but mainly in the digital tomosynthesis now gives three-dimensional digital data. We've said you can slice the breast the way CT scan slices the body. Then we are using tomosynthesis to slice the breast into thinner slices. This is going to help us reduce overlap, further characterize the image, see calcifications better, and improves diagnosis and BI-RADS categorization. So eventually you get higher sensitivity and specificity from tomosynthesis than from plain mammography. It also carries a small risk of increased radiation exposure because it will take a bit longer, but we have ways of doing the digital tomosynthesis first and then synthesizing to get the basic CC and MLO views. These are ways we are trying to use to reduce radiation exposure. Because of the slight increase in time of scanning, there might be some motion artifacts. But now the sensitivity overall for mammography is high, with 85 to 90% in fatty breast. It reduces to 65% in dense breast, and a false negative rate of about 5 to 10%. The main limitations in mammography are due to positioning. So as we continue to sensitize, train, and encourage our mammographers, we are going to get better quality images because the mammographic technique can be a bit uncomfortable for the patient, and we need them to cooperate during the procedure. It also takes a bit of time, changing positioning and talking to the patient. So if you have poor cooperation from the patient, you might have a bit of problems. I'm only putting a few, I don't know if you can see my cursor. Okay, so a few images just to show you mammographic features with abnormalities. And this is a CC view of the right breast. You can see microlobulated margins in these lesions, some areas of calcifications, and they appear to be 2 lesions. In this one, you're seeing actual speculated margins. So this is a BI-RADS 5 lesion because this has high suspicion for malignancy. You can see a small node in the axilla, but it is quite small and it will need further characterization with ultrasound. For these two, these are the same patient. You can see a small area of architectural distortion here, and you might be tempted to think that this is nothing because you can also see a small bulge here. But when you go ahead and do a spot compression magnification view, you can see that there's a lesion here with some irregular margins. So the extra views are very important in mammography. Okay. When we go to mammographic guided procedures, if you have calcifications on mammography without an ultrasound correlate, so you found no mass, but you have suspicious calcifications, you tried to do an ultrasound, you are not able to see anything, then you go ahead and do a stereotactic biopsy or FNA or vacuum-assisted biopsy. And then you can also use this for preoperative localization of those non-palpable lesions by leaving a marker or a wire where the surgeon can localize and excise. When we go to breast ultrasound, we know that ultrasound is user dependent, but we know that it is also readily available. So we can leverage on it to help us increase detection of cancer. It's used mainly as a complementary to mammography for patients with dense breasts and has high sensitivity of about 95% with a negative predictive value of 99.9% and very good in differentiating benign from malignant lesions. We'll see a few images, and it's also used to guide interventional procedures, not only biopsies, but many interventional procedures. So the indications for ultrasound, we had seen women above 40 are the ones who qualify for mammography. So those below, an ultrasound is ideal. For pregnant and lactating women, because of increased breast volume, dilated ducts, milk, and other things in the ducts, then the mammography might appear abnormal and ultrasound is better. And then supplementary ultrasound for people with dense breasts and those with augmentations. to evaluate clinically palpable lesions which are mammographically occult. So you've done CBE, you found a palpable lesion. You did a mammography, there was nothing, then ultrasound will help you. And then as an adjunct, when you want to do targeted ultrasound of lesions, to localize them, of axilla and other areas, and then to guide diagnostic and therapeutic interventions. So the features that you'll see on ultrasound, similar but with different characterizations. So the size, shape, margins, orientation of the lesion, the echo pattern, posterior acoustic features. You're able to check vascularity, and this has a bearing in terms of increase in suspicion. Calcifications, you'll see them, even though you cannot characterize as precisely as mammography, but you'll be able to see them. Elastography, you can do elastography to see the elasticity of the lesions you find, and then associated features. So the findings that we find for lesions which are typically benign, they're usually smooth with regular outlines. They can be round, oval, or ellipsoid with a thin pseudocapsule. So you can draw a pencil around it, and then uniform internal echoes. If it's a cyst, it's totally black, then it's good. And if it has a posterior acoustic enhancement, you're sure, then that is a good lesion. And then no destruction of planes around it. You're able to separate other structures. For suspicious lesions, they're usually irregular, hypoechoic with posterior acoustic shadowing. They can have speculations, posterior enhancement or a halo, and disruption of tissue planes. So you cannot draw clearly the margins around that lesion. So here are a few images showing ultrasound images showing different lesions and how you can describe them. So you have the first one on the top right with lobulated margins. You have the second one with focal bulge. So as much as you can draw the lesion with a pencil around, there's an area with a focal bulge which can increase suspicion. The lower bottom lesions, so you can see a well-defined lesion with posterior, it's hypoechoic with posterior acoustic shadowing. So this is a suspicious lesion. It's also taller than wide. An oval lesion with oriented longitudinally to the body is better than an oval lesion having taller than wide measurements. And then the last lesion on the bottom right, we have calcification. So these are just acoustic shadowings from benign calcifications, which were also seen on mammography. So those are the features you're able to describe. You're able to see vascularity. So you use color Doppler to check whether the lesion is receiving blood flow more than expected. Is it peripheral? Is it intralesional? Or is it avascular? So describing those features will help you come up with a BI-RADS category. And then associated features, we've said things like skin thickening and invasion, chest wall invasion, associated fluids, and other things you can describe also on ultrasound. For elastography, so this not new anymore. It's been in the market for a while, and this evaluates the stiffness of a lesion. So you can use either strain elastography or shear wave elastography, depending on the machine you have, and it will give you a color map. So you'll be able to see based on your color map whether your lesion is hard or it's soft, and it increases suspicion for malignancy if it is hard. So here's an example of an oval, well-defined lesion, which is generally read on elastography, and this indicated that this lesion is hard based on the settings on this machine. So higher suspicion for malignancy and confirmed by biopsy. So for lymph nodes, you had heard that you can assess lymph nodes. You can see some of the lymph nodes on mammography, but you might not be able to characterize them. You can see some size, change in shape, if they have calcifications or central lucent areas. But on ultrasound, you're able to describe further features. So you'll be able to access the axilla, the infra-supraclavicular regions, and describe those nodes. So if you have cortical thickening more than 3 millimeters, change in shape of the nodes. So normal nodes are oval. If they become more circular, then they are suspicious. If they are more than 10 millimeters in the short axis diameter, if they lose the fatty hilum, and if they have internal echoes. So here are examples of ultrasound showing nodes. And the first one, you're able to see a normal node. So the markers are showing the margins of the node. The center, which is hyperechoic, is the fatty hilum we talk about. So the cortex is thin and black, and this is a normal node. Once you start seeing the entire node appearing hypoechoic, then this is a suspicious node, and you have bulging margins or bulging cortex. For example, this one, you're seeing part of the cortex is still thin and normal with a focal bulge. So the measurement here is 6.3 millimeters. We want it to be less than 3 millimeters. If you have a node which is degenerating, so the center looks like it's becoming fluid, necrotic, like this one, then it's also a suspicious node. If you have any node with calcifications in it or with increased blood flow, because the blood flow from the node is supposed to get into the node through the hilum, through this center part. If you put color Doppler and you see vascularity getting from different aspects of the node, then that is an invaded node. So ultrasound guided procedures. Mainly, we do ultrasound-guided biopsies. It increases precision and yield for you to be. You need the hormonal markers. So we are trying to avoid FNA, and the main procedure we do now is biopsy. So number one, you get real-time confirmation that you have gotten the sample. For example, here you're seeing a lesion, and the needle is right inside the lesion. This is before you fire your gun, and after you fire, you've gone right through the lesion. So you're supposed to use a 14-gauge needle. If you don't get one, 16 is acceptable, but 14 is the ideal gauge for breast biopsies to get adequate tissue. For breast MRI, it's highly sensitive, more than 90% contrast-enhanced MRI. You can detect small lesions, and it's particularly important when you have multifocal, multicentric disease. So if you have seen a lesion in ultrasound, for example, intraductal papillomas, which sometimes you might not see all the lesions during that ultrasound scan, some have not caused any ductal dilatation, then MRI will be able to quantify the burden of that disease, or for local staging of non-breast cancer. It's also suitable for dense breast because it's not affected by breast density, and also augmented breast. And when you're following up these patients, when you want to differentiate between postoperative scarring and local recurrence, then MRI is very useful here. When you're looking at treatment response, especially when you want after neoadjuvant chemotherapy, then MRI will give you a good assessment of how your tumor has responded to the treatment. It's the best tool for screening patients with high risk, with a high risk for breast cancer. So the patients with BRCA positive, patients with strong family history, and you cannot keep doing short-term mammograms for them, mainly because of the risk of radiation exposure. Some of them are still young because with the genetic mutations, then you expect breast cancer at a lower age. So it means you start screening these patients from 25 years. So MRI is used in this category of patients. And then patients can also present with nodal metastasis, but you cannot identify a lesion in the breast with the other modalities we've mentioned. MRI is important. So in these cases, the patient is prone, and you use a dedicated breast coil. No breast compression is required, and then you scan different, the way we do normally T1, T2, DWI, and dynamic contrast enhancement, and this will help you pick all the lesions in both breasts. So the advantages of MRI, one, it has superior soft tissue contrast, we all know, and it can differentiate abnormal breast tissue from the normal one. And then multiplanar capabilities, no radiation exposure, so better in patients who need frequent screening, and then an enhanced screening tool, especially in high-risk patients and those with a strong family history. The modalities we had talked about for staging, we had said CT scan of the chest, abdomen, pelvis, and brain. We had said PET CT scan. Different patients go to PET CT depending on different factors. So the oncology team will decide at what point this patient will require a PET, especially when you want whole body staging to make clinical decisions. And this is now where the MDTs come into play and are very important. So for resource optimization strategies, we know the government tried to procure digital mammography equipment with the MES program and placed almost 47 mammograms. Every county had a mammogram. Unfortunately, over time, these mammograms have become decommissioned. They broke down, they were not fixed, they're not being used, and now we are having a new equipment supply, and we hope it will reach most counties. But for counties which are near each other, if you have a mammogram, let's say working in Longisa, and you don't have one in Narok or Kisii or any other place near there, then we just need to communicate and share this equipment to maximize their utilization. Unfortunately, the ones which we had in place were also underutilized already, even though we had them and they're working. And then telemedicine for areas where you have the equipment, but you don't have the radiologists. We know some of the counties did not plan the human resource aspect of this equipment well. Then you need to employ teleradiology facilities so that you can reduce travel costs and increase access to patients who already have these images. And then training local technicians. So we need to improve our local expertise in mammography, ultrasound, biopsy, staging, every aspect of breast cancer management. This will help us go lower in terms of access. So patient doesn't have to travel to the level 5 or the level 6 facility if they can get these things in level 4. So it's important that we assess our capabilities, both equipment-wise, human resource-wise, and technique-wise, and utilize whatever is available to increase this. And we hope that we will manage to do this outside October, so that we carry breast cancer screening awareness throughout the year, and it will make a big difference in terms of early detection, screening, and improved outcomes, so that we are able to keep up with the 60-80-80. This is a picture of Kericho. You're all welcome, and thank you for listening to the talk. You're welcome to the land of tea. Back to you, Tony.
Yeah, thank you so much, Dr. Nuru, for taking up the imaging aspect of breast cancer diagnosis. And also, I can say that your presentation has really shed light in terms of the critical component of early detection and accurate diagnosis of breast cancer. Thank you also for sharing the great picture of Kericho County, where I come from. And I'm happy to really see that. So I also want to sincerely appreciate the panelists because I've seen an active engagement with regards to the questions coming in. You can see that there is a lot of interaction with the audience, with the panelists responding to the questions coming from the audience. So for the last presentation, I want us to move to the final presentation of the night. And we shall be diving into the second modality of breast cancer diagnosis, that is a special focus on pathology. And I want us to learn more from Dr. Shaheen. And I would like to introduce Dr. Shaheen, who is an associate professor and consultant in anatomical pathology and cytology in the Department of Pathology, Medical College, Aga Khan University. Dr. Shaheen is also the current chair and lab director of pathology at the Aga Khan University Hospital in Nairobi. So Dr. Shaheen graduated from the University of Nairobi with a Bachelor of Medicine and Surgery degree.
Okay.
She also holds a master's.
Hi. I'm in the middle of a meeting, so let me just call you back. Hi.
Okay, sir.
Okay, sorry about that.
Dr. Shaheen also holds a master's in medicine in general pathology from the University of Nairobi and a PhD in anatomical pathology from the University of Cape Town, South Africa. She is a fellow of the Royal College of Pathologists in the United Kingdom and a fellow of and Secretary General of the College of Pathologists of East Central and Southern Africa. So she is a commissioner with the Lancet Commission on Diagnostics and the Lancet Oncology Commission for Sub-Saharan Africa. She is passionate about training the next generation of pathologists and researchers in Sub-Saharan Africa. Welcome, Dr. Shaheen for the next presentation titled Pathology as the Cornerstone for Breast Cancer Diagnosis and Management.
Thank you very much, Dr. Tony, for that very kind introduction. And I know I'm like standing between you and your dinner, everyone. And I'm like quite amazed that over 800 participants. So I thank my previous presenters because they've really set the stage, and a lot of what I'm going to say may sound like a repetition. So I'll try and ensure that I've been given 15 minutes, and I try and ensure that within 15 minutes we are done. So just a quick one, Dr. Ojuka mentioned the major structures of the breast, the ducts and the lobules. We have the luminal cells, the myoepithelial cells. We know that the nipple areola complex is the place where about 6 to 10 ducts open. And then these branchings of these large ducts then leads to what we call the terminal duct lobular unit. And that's where all the pathologies from the breast arise. There was a question on the chat about nipple discharge. Yes, usually nipple discharge can affect especially the large ducts. And if you have that, those are the kind of pathologies you can see, Paget's disease, papillomas, intraductal papillomas, duct ectasia, all of these can give you nipple discharge. And then you have various areas of the breast giving rise to different pathologies. So if you understand the anatomy, then you can understand what pathology can arise from which part of the breast. And this is what we look at when we are under the microscope. This is a normal breast lobules. And on the right, someone mentioned women who are lactating, whether they can get cancer, and the answer is yes. So on the right, you have a lobule that has expanded because of lactational changes, and the breast undergoes, those lobules undergo secretory changes during pregnancy and lactation. And then in the female who is older, postmenopausal, a lot of the breast is actually replaced by fat, and that's the reason why the radiologist, sees a less dense breast and easy to pick up lesions even on ultrasound. And then just to again reiterate that the normal breast lobule is what you see on the upper left. That's what it looks like under this microscope. And on the lower side, you see what an invasive breast cancer. So there's a lot of disarray of the ducts. They're all over the place. They're infiltrating into the stroma. Now, when it comes to grading of breast cancers, we grade them as grade 1, grade 2, grade 3. Usually grade 1, the reason we call them grade 1 is because they look like your normal ducts and lobules. And so when you see that, they usually tend to be ER positive, whereas when they're like unrecognizable as ducts, they tend to be grade 3. And usually as well HER2 positive. In terms of how, when we're talking about the intrinsic or the molecular subtypes, there are two broad categories: estrogen receptor positive, estrogen receptor negative, and those which are estrogen receptor positive can also be HER2 positive, and so can the estrogen receptor negative group can be HER2 positive. And these are considered to be intrinsic or molecular subtypes because of the gene expression levels of the various molecules. And that leads to whether they are proliferation markers that are increased or decreased, or whether they're expressing the estrogen receptor at the protein level. So when we look at the estrogen positive breast cancers, is the most common type, even in Kenya. That's the most common type of breast cancer. And they can range from luminal A, which are considered sort of low-grade cancers, to luminal B, which are usually considered high-grade cancers. Prof. Ojuka spoke about the Ki-67. We usually use a 20% Ki-67 cutoff to say high-grade, low-grade, and that divides the luminal A from the luminal B as well. So a lot of these luminal B cancers will also be expressed. Not all of them, but a subset of them will also express HER2. So when you look at luminal A cancers, like I mentioned, that they're good low-grade sort of cancers. They express both the ER and the PR at very high levels. They are HER2 negative. Their proliferation, the Ki67, usually much less than 20%, grade 2 usually. And you can have special subtypes. So a lot of them are just ductal carcinoma, no special type, but they can be subtypes of breast cancer like the tubular mucinous and lobular that are usually grade luminal breast cancer or grade 1 cancers, grade 1, 2. Most of them, if they're having mutations, it involves the entire chromosomes, and the most common mutation would be the PIK3CA mutation. Then when you come to luminal B, remember we mentioned luminals, the higher grade is luminal B, which does not look like your normal breast tissue. Usually the ER in these patients is very low, and PR can be negative. HER2 can be negative or positive, and usually have a high proliferation rate, tend to be grade 2, 3. And it's the most common type of cancer in individuals who are BRCA2 germline mutations, if they are HER2 negative. So when you look at the MET pattern, in these patients who are ER positive, their metastatic pattern, usually bone more than lung, more than brain is much less likely, and they can survive for many, many years. They have better prognosis than those who are ER negative, stage for stage. So for the first 15 years, then after the 15 years, because of endocrine resistance and the slow growing nature of some of these tumors, you end up having similar survival rates as outcomes as those who are ER negative. What about triple negative breast cancers? They have a marked genomic triple negative, means that they're ER, PR, and HER2 negative. They have a lot of genomic instability, and the most common mutations in these tumors are actually TP53. Dr. Ojuka mentioned again basal cell type. It's not all triple negative breast cancers are basal type. So I don't want to confuse you. Just remember that triple negative are ER, PR, HER2, all triple negative. Let's go next. So usually triple negative, like I mentioned, all the 3 markers are negative. They're usually grade 3. There are certain specific types or subtypes of breast cancer that are triple negative, almost invariably metaplastic carcinoma being one of them, and most of them are associated with BRCA1 germline mutations. However, remember there is a category of triple negative breast cancers that have a very favorable prognosis, and these are the secretory, the adenoid cystic, and the adenosquamous. Distant metastasis, more to viscera and brain compared to ER positive. Remember, the brain was less in ER positive tumors, but in triple negative tumors, the brain is about 25, the bone is 40%, so death usually occurs shortly after recurrence. So if there is a recurrence in a short interval, then invariably they tend to not do well, and long survival with metastasis is not very likely. When it comes to neoadjuvant chemotherapy, about 30% of TNBCs or triple negative breast cancers will undergo complete pathologic response. That means there's no tumor post chemotherapy, and some of these are actually considered to have been cured. Like we mentioned, ER negative tumors have a worse outcome than ER positive cancers. And if death occurs, it will be in the first 8 years. And after 8 years, it's very rare. So those who survive, the 8 years will probably live for another, 20 years. What about HER2? HER2 positive breast cancers, there's only one way that the HER2 can be overexpressed, and that is that you have an amplification of the gene, and then you result in, when you're doing your immunohistochemistry, your HER2 is what we call overexpressed. These tumors or HER2 positive tumors, about half and half are ER positive and ER negative, respectively. And usually, if they are HER2 positive, ER tends to be negative. If they are completely and uniformly HER2 positive, they're usually grade 3 as well. And in terms of metastasis, it occurs both in the bone and the visceral side. So if you look at HER2, those which are ER positive as well, they will have features of both triple negative in terms of high proliferation, rapid recurrence to visceral sites, as well as ER positive. And long-term survival data is pretty good at the moment, and I'm sure the oncologists on the call can tell us how their HER2 patients behave, those with or without ER expression. Now, in terms of how do we assess HER2, we use immunohistochemistry, and there's a 0, 1+, 2+, and 3+. 3+ means positive, 2+ means equivocal, meaning you can't tell whether it's positive or negative. You have to do additional testing, which is the what we call in situ hybridization or FISH testing, to determine whether it's positive or negative. And then 1+ and 0+ have always been considered as negative. However, in the MET setting and currently, the new guidelines have demonstrated, and there are trials like the Destiny 0406 trials, which have demonstrated that even those patients who are 2+ on immunohistochemistry end up going for FISH. FISH turns out to be negative, or those who are 1+ on immunohistochemistry, or those who are 0+ on immunohistochemistry, and their criteria for how you determine what is a 0+ or a 1+ or a 2, a 2+. Those patients in the metastatic setting are eligible for therapy with antibody drug conjugate, TDXD. So those are the kind of drugs that are currently available in the MET setting. So as far as those who are purely HER2 0, currently it's not known if they would also respond to TDXD. And so the new guidelines state that as far as pathologists are concerned, we will continue reporting them as 3+ positive, 2+ equivocal, going for FISH, 1+ negative, 0. However, there is a category of 0+, and there is a caveat, and you can see a lot of our reports currently will have this sort of a comment, a narrative comment about the Destiny trial and the new reporting system. However, at the end of the day, when we are reporting, we would just, in the final summary report, we just give you the score. It is for the oncologist to determine whether this will be considered ultra low or what we call HER2 low. So those are the new guidelines for HER2 reporting. In terms of biomarkers, when we are testing for biomarkers, the most important, and there was a question on the chat box, is there a possibility of having a core and a definitive specimen, like a surgical specimen, discrepant ER, PR, or HER2 results? Absolutely, very possible. The best specimen to use for biomarker testing is a core biopsy. However, if you don't have a core for any one reason and the patient has had surgery based on perhaps on an FNA diagnosis, then in that case, fixation and the pre-analytic aspect matters a lot to ensure that you have an accurate assessment of your biomarkers. And when I say pre-analytics, I'm talking about how you collect the specimen, how you fix it in formalin, how it is prepared in the lab before the analysis can be done. Of course, there are also errors down in the interpretation or the technical aspects of the test, but 95% or more of the cases is the pre-analytics, or what happens to the specimen before we cut it up, that really matters as to the accuracy and ensuring that you get accurate reports. And so here we talk about the cold ischemic time. Is the time between when the surgeon cuts off the blood supply, when they're cutting it off, removing, let's say, a breast lump, or doing a lumpectomy, or cutting the lump, and the time they immerse it into formalin. That time is crucial, and that's what I'm saying about the pre-analytics. So if that time is delayed, already there is a decay in the antigen levels, and therefore when you're testing it in the lab, it's like garbage in, garbage out. So ER, as an example, after 2 hours, if you don't fix the specimen within an hour or so, there will likely be a report that says ER is negative. And the same for PR. So within an hour, that specimen, if possible, immediately the specimen is removed by the surgeon, should be immersed in formalin. And then, especially with the low positives, it can easily change from a positive to a negative report. And in terms of, remember that, when you put it in, immerse the specimen in formalin, the formalin itself penetrates only at 1 millimeter per hour. So if you have a huge breast measuring 1.2 kilos, you can imagine by the time the formalin is reaching that tumor, it's going to be, hours and hours. So it takes a long time. So that's why we advocate that as soon as the specimen is immersed in formalin, it needs to get to the lab. And if the surgeon doesn't want to do it, the lab should handle it immediately. Make sure that you slice it so that you expose as much of the surface of that breast, of that specimen to formalin, so that there is at least a faster sort of penetration of formalin, in the sense that you're exposing more surface. So there's lots more, formalin going in. Not really at faster in the sense, but that, you're allowing a lot, rather than it going through at that 1 millimeter per hour, you're giving more surface exposure. So that's what we do. We slice, we mark, we make sure that margins are inked, and we also insist that the surgeon marks, the margins appropriately. And then when it comes to when we are grossing the specimen, we like to take a bit of the normal and the tumor. We like to make sure that we take a section for, especially for ER/PR HER2 testing, at the edge of the tumor where it is better preserved than at the center. Remember, the center of the tumor, chances are it will be necrotic. So at the edge of the tumor, take a bit of the normal as well, and the normal acts as an internal control. In terms of grading, you've heard people say, what is grade 1, grade 2, grade 3? It's a simple system. However, it can have some inter-observer differences, but we're looking at how the glands, we're looking at how bizarre or atypical the nuclei are, and we're also counting mitoses. So again, why grade the tumor? Because it's a strong prognostic factor for survival, whether they are in treated and untreated populations, and those have been documented very reliably. And when we look at grade, when we're looking at tubule and we score what proportion of the tumor is actually forming tubules, the more the tubule formation, the lower the score for the tubules. So, for example, at the top there, you find that 75% of your tumor area is forming tubules. You can actually see the lumen of those tubules. So that's a grade, it's a lower score. We score it 1. And then the one at the bottom, you hardly see any tubule formation. So that's a score 3. So that's how we decide for the tubules. And then when it comes to nuclei, we also look at nuclei. And then we decide, okay, fine, are the nuclei or the nuclear size, is it similar to our normal glands? And if it is, then it's a nuclear grade 1. But if they're bizarre nuclei, pleomorphic, very, maybe even giant cells, then they're scored 3. And then we look at mitoses as well. Now, again, remember when we talked about the cold ischemia time, the time the surgeon removes the breast and immerses it into formalin has to be within an hour, or immediately or within an hour for that matter. However, if you prolong it more than 6 hours before you immerse that specimen, it can result in a decreased mitotic count. And if that happens, that means you're going to score it maybe a lower score for mitosis than it should be. and you'll give it a wrong grade. So sometimes we really face these issues where we can't even count mitosis, we cannot grade the tumor, and we know that grade is a really important for prognosis. And so again, when we are looking at overall grade, like I mentioned, we are looking at tubules, we are looking at nuclear pleomorphism, and we are counting mitoses. And when we combine all this, each element, whether it's the tubule or the mitosis or the nuclear pleomorphism, is scored 1, 2, or 3, and we then add up all the 3 component scores and come up with a grade 1, 2, or 3 as the overall grade. So this is just an example of a kind of specimen we sometimes get where you have a small, this is a whole mastectomy specimen. Prof. Ojuka will be shocked that sometimes we do get this sort of specimen where the whole breast is squeezed into this small container. And what do we see then? If you look at the upper half and the lower half, the upper half, the tumor, we can't grade it because you can't see anything. It's just a blob of pink and red. And then on the right is an ER stain, and you can hardly make out if some of those nuclei are positive. But the same specimen, in the same patient, a lymph node, because the lymph nodes are smaller, so the fixation is sort of easier in a lymph node because the formalin has to travel a shorter distance. You can see that one would be able to grade the bottom bit, and you can see the tumor itself, and you can see the same patient with the same node having an ER positive, 91 to 100% positive score. And in terms of ER/PR testing, we look at anything is more than 1% as positive. Anything more than 1% cell staining is positive. Anything less than 1% becomes negative. There is a category of 1 to 10%, which is low ER low positive, and those sort of tend to behave like triple negative breast cancers. One of the important things when I mentioned that when you're cutting sampling the tumor, we like to take a bit of the normal and the tumor, and we like to do it at the edge where we see a bit of the normal. And the reason being, if you want to know that your ER stain is working, your little normal ducts, which are embedded sometimes within the tumor or even outside the tumor, should stain positive. And if they don't, you know that your stain has a problem. There's a problem. So this is what we call internal controls. And sometimes when you have a lot of cautery artifact, all these can give you, these are the reasons why you can get false negative when you're cauterizing, because if you have cold, like I said, ischemic time is prolonged, or you fix that tissue in formalin for weeks and weeks before it gets to the lab. Decalcification as well. What about HER2? HER2, we mentioned the 0, 1 plus, 2 plus, or the 3 plus, and that's how we look at it. What about breast cancer staging? Dr. Ojuka, really Prof. Ojuka went through the staging, but we look at the what we call also the TNM, tumor size, nodal status. We don't report metastasis because as pathologists, we don't know unless we have tissue from the metastatic site on which we've done histology and we can actually see there's a met, whether it's in the liver or the brain, then only are we allowed to report on the mets. So we can assign M1, but even we can never assign, PM0, even at autopsy. We don't do it. Like I said, we cannot provide M. So the stage is the medical oncologist who determines. 60% of women with palpable cancers have regional node metastasis, and this is the most important prognostic factor for this group. And for women whose nodes are free of cancer, features of the primary carcinoma are most important. And so this is the categories that we used. TIS is carcinoma in situ, microinvasion, T1, and T1 is divided depending upon the size of the tumors, and right up to T4, which is inflammatory cancer. So when we are measuring the size of the tumor, it's very important to understand that we only measure the T category based on the invasive components. If it's a DCIS, we don't include that in our measurement. What about inflammatory breast cancer? So if you look at, the definition of the 7th edition AJCC requires diffuse erythema, more than 1/3 of the breast skin. It's diagnosed based on clinical appearance. And as pathologists, the erythema and edema usually is not apparent to us. So this is the only T category that cannot be assigned based on pathologic examination, because dermal lymphatic or lymphovascular invasion is not always extensive enough to cause the symptomatology. So you have this large erythematous breast, and what happens is that you have tumor in the dermal lymphatics which are blocking the drainage from the breast, and that's what we see. They may not be a mass lesion, usually not a mass lesion, but just the whole breast appears engorged. And so as far as we are concerned, we will provide the T and the N categories, and then the oncologist provides the M category, and that determines the clinical stage. So in terms of what do we use to report, these are all the parameters that we wish all surgeons, would be able to provide us. The site of the tumor, are they multiple? Is it multicentric? What is the size? What is the imaging characteristic? So if all that information was provided to the pathologist, it would make our lives easier, because a lot of the times we delay sometimes reports because we are waiting on some radiology information or information from the surgeon. Sometimes we don't even get the laterality. Sometimes we don't have margins designated as well. So when it comes to margins, it's important again for the surgeon to label the margins. L, lateral, so long suture for lateral, short superior. But I think this at least has improved over the years, and most surgeons you find, in fact, I think 99% of the surgeons do mark or designate the margins of whether it's a lumpectomy or mastectomy. So when it comes to margins, margin evaluation is an exercise in probabilities. It's not absolutes. Patients who have positive margins are more likely to have residual disease at or near the primary site than those with negative margins. But remember, a positive margin does guarantee residual disease. So if you have some patient who has a positive margin, definitely it means there is residual disease. However, a negative margin does not preclude extensive residual disease. So having a negative margin, like I said, it's not an exercise in absolutes, it's probabilities. And thank you so much for your attention. Happy to, I hope I've done my 15 minutes and not more. Thank you.
Yeah, thank you so much, Dr. Shaheen, and a big thank you as the final presenter for that excellent session on pathology. I can acknowledge that it's such a clear and insightful presentation to wrap up the discussion on breast cancer diagnosis. So we really appreciate the knowledge that you have imparted to this audience during this evening. So I think we are just going to take a look at the quiz that we just had, and we can take the quiz for the next around 2 minutes, and then we can wrap up the evening. So I really appreciate also the panelists as we proceed, because I can see that apparently the questions that were shared on the chat box were really tackled well. And maybe even as we proceed, for the first question, we can see that late staging diagnosis and limited access to treatment was actually having most of the participants as the response. That was the correct answer. Looking at the second question, that was looking at the key international policy framework, addressing cancer control, including breast cancer. That is the WHO Global Breast Cancer Initiative. That was the correct answer. And the third question, the diagnostic tools are considered as the gold standard for early detection of breast cancer. The correct answer is mammography. The fourth question, the immunohistochemistry marker that is used for determining hormone receptor status, breast cancer pathology. So that is the ERPR, estrogen and proestrogen receptors. And then the last question, as the recommended treatment approach for early breast stage treatment, that is a combination of surgery, radiation, and or systemic therapies. So I also want to take this opportunity to also welcome Dr. JP so that we can share the slide that has the National Cancer Control Strategy, or rather the National Cancer Control Program social media handles, so that we can be able to follow as participants. I also want to take this opportunity to thank KENCO and KNH for the partnership and support that has enabled this webinar to be successful, and also the Breast Cancer Awareness Month planning team that has enabled us to have this opportunity to undertake this webinar. So I can't forget to really thank the attendees from the different counties and regions for creating time to be with us. I know it's late in the evening and we've gone past the hour. So we really appreciate your commitment and enthusiasm. So even as we commemorate Breast Cancer Awareness Month on this October, we continue to amplify the messaging around breast cancer early detection and timely diagnosis, because we do know that awareness alone is not enough. So therefore, our actions and also voices and collaboration is key to ensure we make a difference in averting the 9 deaths that arise from breast cancer daily. So thank you so much for the participants for waiting up to this moment. So also to our presenters, I think those were really insightful, and thank you for even taking up the questions as they came. So Dr. Bor, I don't know whether you can be able to share that slide. Yeah. So the next slide, yeah. So those are the social media handles for the program. You can be able to follow us through LinkedIn, the Facebook page, Instagram, and also at X. So the social media hashtags are displayed, and also the website for the National Cancer Control Program, whereby you can be able to access all these policy documents and be able to download the soft copy version. So thank you so much for all the participants, and we really wish you a blessed night. Thank you, and bye.
Thank you, Tony, for moderating well.